If you've ever looked at a wound and wondered whether it's healing the way it should, or if something's quietly going wrong that you can't quite name yet, this video is for you. I'm going to walk you through the difference between acute and chronic wounds in a way that's practical, clear, and immediately useful. Whether you're brand new to wound care, you've been doing this for years, or you're responsible for making sure your facility stays safe and compliant. You don't need a textbook or memorize categories. You just need to understand what makes a wound move toward healing or get stuck, and what that means for the decisions you make at the bedside. This is so crucial because the difference between these two types of wounds changes what you do, what you document, how you protect your patient, and how you protect yourself and your facility from risk. And there's one mistake that turns a manageable wound into a chronic problem. And most people don't realize they're making this mistake until it's too late. I know all of this because I've spent years working in wound care across hospitals, skilled nursing facilities, and home health. I've reviewed charts where the documentation didn't match what was actually happening. I've walked into rooms where a wound has been treated the same way for weeks, even though it wasn't responding. And I've seen what happens when someone finally asks the right question and everything shifts. This isn't theory. This is what I've learned from real cases, real mistakes, and real outcomes. So in the next several minutes, I'm going to walk you through all of this step by step. And by the end, you're going to know how to look at a wound and understand what's really going on. Not just what it looks like, but what it's telling you about what comes next. Let me start with what an acute wound actually is. An acute wound is a wound that happened recently and is moving through the normal stages of healing in the expected time frame. So think of a surgical incision. Think of a clean laceration from a fall. Think of a pressure injury that just appeared yesterday. The tissue knows what to do. The body's repair system kicks in. Inflammation happens, new tissue starts forming, and if nothing gets in the way, the wound closes. It's predictable. It follows a pattern. The edges come together, the base fills in, the size shrinks. You can measure it this week and measure it again in 2 weeks and see progress. That's an acute wound. It's on a timeline, and that timeline is moving forward. But what most people don't realize is that a wound doesn't always stay acute forever. If progress stops, if the wound sits there week after week looking the same or getting worse, it crosses a line. It becomes chronic. And that's not just a label, that's a completely different biological situation. A chronic wound is a wound that has failed to progress through the normal stages of healing in the expected time frame. Most definitions say that's 4 weeks, but honestly, if a wound isn't showing clear signs of improvement in 2 to 3 weeks, you should already be asking why. Chronic wounds get stuck. The inflammation doesn't resolve. The tissue doesn't rebuild. The edges don't migrate inward. Instead, the wound sits there, sometimes for months, sometimes for years, in a state that looks like healing but isn't. The body is trying, but something is blocking the process. Maybe it's poor blood flow. Maybe it's infection. Maybe it's pressure that never got relieved. Maybe it's malnutrition or uncontrolled diabetes, or edema that won't go away. Whatever it is, the wound can't finish what it started. And the longer it stays open, the harder it becomes to close. That's the danger. Chronic wounds aren't just slow healers. They're wounds that have fundamentally lost the ability to heal without intervention. And if you keep treating them like they're acute, you're going to keep missing what they actually need. Let me tell you the most common mistake I see. Someone looks at a wound, sees that it's clean, sees that there's no obvious infection, and assumes it's healing. They keep using the same dressing. They keep doing the same care plan. They document that it's stable, and weeks go by, maybe a month, maybe 2. And then someone finally asks, why hasn't this closed? That's the mistake. Treating a chronic wound like it's acute, waiting for it to heal on its own, when it's already shown signs to you that it can't. Here's what happens physiologically when a wound becomes chronic. The normal healing process depends on a careful balance of inflammation, cell growth, and tissue remodeling. In a chronic wound, that balance is broken. Inflammation becomes prolonged and destructive instead of helpful. The cells that are supposed to rebuild tissue get stuck in a loop. They keep trying to start the process over, but they can't move forward. The wound bed fills with old, damaged tissue that doesn't support new growth. Bacteria colonize the surface, and even if they're not causing a full-blown infection, they create a low-level inflammatory burden that keeps the wound from progressing. Blood flow is often compromised, so oxygen and nutrients can't reach the tissue. Waste products build up. The edges of the wound become rolled or thickened, which is a sign that the cells have given up trying to migrate inward. And the longer this goes on, the more the wound environment becomes hostile to healing. You end up with a wound that looks okay on the surface, but is biologically stuck. And here's what that means in real terms. First, the patient stays at risk. An open wound is a doorway for infection, for pain, for loss of function, for decline. Second, the wound becomes harder and more expensive to treat. You're not just managing a simple dressing anymore. You're managing biofilm, you're managing inflammation, you're managing tissue that won't respond to standard care. Third, your documentation and your care plan are now under scrutiny. So if a wound has been open for 6 weeks and you're still calling it stable and using the same approach, that's a red flag in an audit. That's a question in a survey. That's a gap that someone is going to ask you to explain. I've seen this happen. I've walked into facilities where wounds were documented as stable for months, but when you actually looked at the measurements, they hadn't changed at all. No improvement, no deterioration, just stuck. And the staff didn't realize that stuck is not the same as stable. Stuck means something is wrong, and you haven't figured out what it is yet. I know this can feel overwhelming. So you're managing a full patient load, you're dealing with staffing shortages, you're trying to keep up with documentation and orders and families and everything else. And now I'm telling you that you need to think differently about wounds that aren't healing. I get it. Even experienced clinicians second guess themselves. You look at a wound and you think, is this normal? Should I be worried yet? Am I missing something? And that uncertainty is exhausting. That's exactly why I created the Wound Care Circle. It's a community where you can get weekly guidance, real case breakdowns, and practical help from someone who's been doing this for years. It's a place where you can ask questions from the community, get clarity, and feel supported without the overwhelm. If that sounds like something you need, I'd love to have you join us. You can find the link in the description. So what do you need to do first when you're looking at a wound and trying to figure out if it's acute or chronic? Well, you need to ask 3 questions. 1, when did this wound start? 2, has it shown measurable improvement since it started? And 3, what factors might be blocking healing? Let me break that down. When did this wound start? If it's been less than 2 weeks, you're probably still in the acute phase. If it's been more than 4 weeks, it's chronic by definition. But even in that 2 to 4 week window, you need to be watching closely. Has it shown measurable improvement? That means the wound is smaller, the depth is less, the tissue looks healthier. The drainage is decreasing as well. The edges are moving inward. If none of that is happening, you don't wait for another month to act. You start asking why. What factors might be blocking healing? This is where you look at the whole patient. Is there adequate blood flow? Is there pressure being relieved? Is nutrition adequate? Is diabetes controlled? Is there edema? Is there infection or biofilm? Is the patient on medications that impair healing, like steroids? You can't treat the wound in isolation. You have to treat the person. And if you don't address the underlying factors, the wound will still stay stuck no matter what dressing you use. Now, let me give you some clues you can spot before any tests come back. These are the things you can see with your own eyes that tell you a wound is moving toward chronic. First, the wound edges are rolled or thickened. That means the cells at the edges have stopped trying to migrate inward. Second, the wound bed is pale, dusky, or covered in a layer of yellow or gray slough that doesn't clear with cleaning. That's a sign of poor perfusion or biofilm. Third, the wound has been the same size for 2 weeks or more. No shrinkage, no depth reduction, just static. Fourth, there's persistent drainage that doesn't decrease over time, even with appropriate dressing changes. Fifth, the surrounding skin is discolored, indurated, meaning inflamed, or showing signs of chronic inflammation like hyperpigmentation or fibrosis. And sixth, the patient reports that the wound isn't painful when you'd expect it to be, or it's excessively painful without obvious cause. Both of those can be signs of nerve damage or ischemia. These signs mean proceed with caution. They mean this wound is not behaving like an acute wound, and you need to adjust your approach. And the counterintuitive part that most people get wrong is that they think that if a wound looks clean, it's healing. But a chronic wound can look clean and still be stuck. Clean doesn't mean healing. It just means there's no obvious necrotic tissue or purulence at that moment. A wound can be clean and still have biofilm. It can be clean and still have inadequate blood flow. It can be clean and still be under pressure every time the patient sits or lies down. The mistake is assuming that clean equals progress. What you should be looking for is not just cleanliness, but change. Is the wound getting smaller? Is new tissue forming? Are the edges moving? If the answer is no, then clean or not, that wound is not healing. And the safer, smarter alternative is to stop waiting and start investigating. That means reassessing the patient. That means involving the provider. That means considering advanced therapies, specialty referrals, or a completely different approach to offloading, nutrition, or infection control. It means documenting that the wound is not progressing and explaining what you're doing about it. Let me tell you about a patient I took care of a few years ago. She was in a skilled nursing facility and she had a pressure injury on her sacrum. It had been there for about 6 weeks. The documentation said it was stable. The dressing orders hadn't changed. When I looked at it, the wound was clean. There was no odor. The tissue was pink. But when I measured it, it was the exact same size it had been 4 weeks earlier. I pulled up the old measurements. No change. Not even a millimeter. I asked the nurse, has anyone talked to the provider about this? She said, well, it looks good, so we just kept doing what we were doing. That's the moment everything clicked for me. This wound looked good, but it wasn't healing. It was stuck. I checked the patient's albumin. It was low. I checked her hemoglobin. Also low. I looked at her dietary intake. She was barely eating half her meals. I checked her repositioning schedule. It was written in the care plan, but when I asked the aides, they said she refused to turn most of the time because it hurt. So we had a wound that looked clean, but the patient was malnourished, anemic, and still under pressure. No wonder it wasn't healing. We got the provider involved. We started a high-protein supplement. We addressed her pain so she could tolerate repositioning. We added a specialty mattress, and within 3 weeks, that wound started to shrink. Not because we changed the dressing, because we changed everything else. That's what I learned. You can't heal a chronic wound with a dressing alone. You have to fix what's blocking the healing. So here's what to do instead. When you're managing a wound, especially one that's been open for more than 2 weeks, follow this plan. Step 1 is to measure the wound every week. Length, width, depth. Document it. Compare it to the previous measurement. If there's no improvement in 2 weeks, escalate. Step 2, assess the whole patient. Nutrition, hydration, blood sugar, circulation, pressure relief, pain control, medications. Don't just look at the wound. Look at the whole person. Step 3 is to clean the wound appropriately, but don't overclean. Gentle irrigation with saline or wound cleanser is enough. Scrubbing damages fragile new tissue. Step 4 is to choose a dressing that matches the wound's needs. If it's dry, you need moisture. If it's wet, you need absorption. If there's slough or biofilm, you may need a debriding agent or antimicrobial dressing. But don't just use the same dressing because it's what's on the cart. Step 5 is offload pressure completely, not just reduce it, eliminate it. If the wound is on the heel should be floating. If it's on the sacrum, the patient should not be lying on their back. Step 6 is to involve the provider early if the wound isn't improving. Don't wait a month. 2 weeks of no progress is your signal. And step 7 is to document everything. What you see, what you measure, what you did, and why. If the wound isn't healing, your documentation should reflect that you noticed and that you acted. When you do it right, the wound starts to shrink. The edges soften and begin to migrate inward. The tissue in the base becomes more vascular, more pink, more alive. The drainage decreases. The patient reports less pain. The measurements show consistent improvement, week over week. And eventually, the wound closes, not because you got lucky, but because you identified what was blocking healing and you removed those barriers. You gave the body what it needed to do what it's designed to do. That's what good wound care looks like. It's not magic. It's not complicated. It's just paying attention, asking the right questions, and acting on what you see. And when you do that, healing becomes possible again. You give the patient a chance. You protect yourself and your facility. And you prove that wounds don't have to stay stuck forever. Before you look at the size of a wound, before you decide what dressing to use, before you document that it's stable, check the timeline. How long has this wound been open? Has it shown measurable improvement in the last 2 weeks? Are the edges moving inward, or are they rolled and stuck? Is the tissue filling in, or is it staying flat and pale? Is the drainage decreasing, or is it the same week after week, or increasing? These details reveal everything. They tell you whether the wound is healing or whether it's stuck. They tell you whether your current approach is working or whether you need to change course. They tell you whether it's an acute wound moving towards closure or whether it's across the line into chronic and needs a completely different strategy. But noticing these signs is only half the story. The real challenge is knowing what to do once you see them, because that's where most people get stuck. They recognize that something's wrong, but they don't know what to change or how to escalate or what questions to ask the provider, which is why I made a video showing you a simple framework for assessing wounds that takes the guesswork out of it. You'll know what to look for, what it means, and what to do next. So click this next video on your screen where I explain how to assess any wound with confidence, that show you how to make decisions that actually move the needle towards healing. Stay informed and heal well.